Good morning. I'm here to tell you about a very bitter pill. Medicare has a drug problem. It's called self-administered drugs. These are the pills that are in your medicine cabinet, the drugs you take every day. You get them at your local pharmacy. And most seniors have quite a few of them. And this is the real story of George, the true story of George, and his drug problem. You see, George is diabetic, and one day he had chest pain, so he went to the emergency room. But he wasn't too worried because he has Medicare and a supplemental insurance, so he knew he'd only have to pay about $50. And that's where George's drug problem began. He went to the pharmacy and got his usual medications. But when he had to go to the emergency room, he found he couldn't take those drugs into the hospital or into the emergency room. It's a violation of state law and hospital accreditation rules. So while he was there, the hospital gave him the insulin he needed as a diabetic. They gave him his other medications while they held him overnight for observation. You see, he wasn't ever actually admitted to the hospital. He remained an outpatient the whole time. And that's the second barrier. Medicare will only pay for outpatient medications that you obtain from a local pharmacy, the ones he couldn't bring in. And that's the problem we decided to work on. So this is the result. George's bill from the hospital was about $13,000. Medicare took care of most of that, but he had a very unexpected balance of $1,287 for self-administered drugs. Those are the drugs he paid about $62 for at the pharmacy. This is a big problem. It affected over 1.5 million people in 2012 for just under $200 million billed to Medicare beneficiaries. Medicare says it covers their drugs, but in this case, it doesn't. So we had a good idea, or we thought it was good, a new tool that connects hospitals to Medicare drug plans and allows them to bill just like a pharmacy would. And we took that idea to hospitals, dozens and dozens of hospitals, to talk to them about it and see what their reaction was. And we talked to every kind of stakeholder that you might imagine. What we found was not one single hospital was interested in our tool. They thought it was too much work for too little reimbursement. We learned that hospitals spend millions and millions of dollars chasing reimbursement for these drugs that just aren't covered. We learned that many hospitals have already stopped billing for them because it just makes their patients so angry. But of hospitals that do continue to bill, 90% would stop tomorrow, except they think there's a federal law that requires them to issue a bill to the patient. So we thought we'd take a look at that law and see if maybe we could fix that. So here's our quick fix. We found the source of the confusion. It's not a law, it's a memo from 2003 from CMS to our payment contractor that said hospitals don't have to bill for these drugs, but if they don't, they might violate a couple of provisions of the Social Security Act. That has caused hospitals to bill for years. So we got a legal opinion that says this is not a violation of the Social Security Act. Hospitals really don't have to bill, not a problem. So we've gone to the Inspector General's office, to their industry guidance branch, and asked them to consider guidance to industry, making it very clear they're not required to do this. And we hope that'll be released quite soon. We think this will stop about 90% of these bills, or $150 million billed to our patients. The next step is the permanent fix. It's comprehensive. It requires legislation, however. About the time of the Ignite Boot Camp, the Medicare Payment Advisory Commission, or MedPAC, issued a recommendation to Congress to bundle these drugs into the outpatient prospective payment system, the system that pays for emergency room visits. Now we're asking CMS and HHS to get on board to recommend the President include this in his budget to Congress, and Congress can pass this in a budget-neutral way to solve the problem. Thank you.